All right, good afternoon, everyone. Hello, it is my pleasure to welcome you today to Susan G. Komen's virtual Metastatic Breast Cancer Impact Series event. My name is Gina Chicotel, Senior Project Manager for Mission Partnerships at Susan G. Komen. The programming for this series is envisioned as a year-long conversation with attendees, presenting new information and speakers each month. Today, our topic is metastatic HER2-positive breast cancer. Our featured speaker is Dr. Heather Parsons, and our fantastic moderator is Julia Hughes, a member of Komen's Metastatic Breast Cancer Steering Committee. Before we begin, Komen would like to thank our sponsors for supporting the 2024 MBC Impact Series. Thank you to our premier sponsors, AstraZeneca, Gilead, GE Healthcare, and Merck, and our signature sponsors, Walgreens and Daiichi Sankyo. This series is made possible because of their generosity. One more housekeeping note. While our speakers are talking, please feel free to post your questions in the Q&A feature in Zoom, and we will get to as many as we can. Please remember, our speakers are not able to provide individual medical advice and are only speaking to their experiences. Towards the end of our program, a survey link will be placed in the chat. Your feedback on this survey is very important to us and helpful as we schedule out and plan future MBC programs. Now, we are excited you are all joining us for today's discussion. To start, I would like to introduce you to our moderator, Julia Hughes. Ms. Hughes has been living with metastatic breast cancer for 9 years, with vast personal involvement in breast cancer topics, skilled in communication, organization, and community support. She wants to help Komen address the needs of the MBC community while ensuring diverse voices and perspectives of the MBC community are included. She has been on a roller coaster journey since her original diagnosis in February 2015. After 5 chemos, hair loss, a bone biopsy, and scans, there was a change in diagnosis to metastatic breast cancer in June of 2015, and she was told she had 6 months to live. Now, 9 years later, she's had over 55 IV chemo treatments, gamma knife radiation, brain surgery, double hip surgery, and oral meds. She has fundraised for Komen Hawaii, leading the top team in dollars raised, spoken at the 2019, 2023, and 2024 Susan G. Komen Pink Tie Ball, and was the More Than Pink Inspirational Award winner in Hawaii. She was also on the cover of Generations magazine, promoting awareness of breast cancer in all age groups in 2019. Julia, I will let you take it from here.
Thank you, Gina. I really appreciate being here today and having the opportunity to work with Komen and the Impact Series. And I'm excited to announce our speaker. I too have HER2 positive. So here today we are welcoming Dr. Heather Parsons. Heather Parsons is a doctor, MD and MPH, medical oncologist at Dana-Farber Cancer Institute and assistant professor of medicine at Harvard Medical School. Dr. Parsons' research focuses on breast cancer and the use of blood-based genomic biomarkers to understand the course of a woman's breast cancer and response to treatment. Ultimately, she aims to develop these biomarkers to better direct existing treatments, to avoid overtreatment, and to develop new treatments to help patients live better, longer lives. Dr. Parsons is a graduate of Dartmouth College and has a Master of Public Health from Johns Hopkins Bloomberg School of Public Health. She received her medical degree from Drexel University College of Medicine, where she was inducted into the AOA Honor Medical Society. She was then an OCR medicine resident in internal medicine at the Johns Hopkins Hospital. She completed a fellowship in medical oncology at Johns Hopkins Hospital before joining the Susan F. Smith Center for Women's Cancers at DFCI. She is currently an instructor at Harvard Medical School. Dr. Parsons cares for patients with breast cancer as a medical oncologist at DFCI. Her research focuses on the use of blood-based biomarkers to understand, and in doing so, to better treat patients with breast cancer. She is supported by awards from the Susan G. Komen Foundation and the Terry Rogier Breast Cancer Foundation. Welcome, Dr. Parsons. Thank you for being here.
Thanks so much. Looking forward to the discussion today. There we go. And I will make sure everyone can see my slides. Whoops. Are you able to see them? Where did it go? There we go. Hold on one second. There we go. Okay, great. So thank you so much to Julia and to Susan G. Komen for the invitation to speak here today. I'm hoping to keep our conversation to do a presentation, but then also I'm looking forward to questions and discussion with all of the participants. So we're going to focus on HER2-positive metastatic breast cancer and then liquid biopsy, which is a focus of my research and sort of the combination of these two to guide care. My slides are not advancing. Hold on one second. I'm going to reshare. There we go. And go like that. There we go. Okay, there we go. These are my disclosures. So I think this audience is familiar with this, but it's always good to start to keep us on the same page and thinking very briefly, just what is metastatic breast cancer very generally. Breast cancer, metastatic breast cancer is breast cancer that has spread from the breast and the lymph nodes to other areas of the body. And typically this happens years after the initial diagnosis and breast surgery. But in some cases, the cancer is metastatic already at the time of diagnosis. And when this happens, we call it de novo metastatic breast cancer. And this is important because although it only represents 6% diagnoses overall, it's much more common in HER2-positive breast cancer. We know there are about 150,000 patients living with metastatic breast cancer in the United States, and that many treatments are available for all forms of metastatic breast cancer. But currently, the treatments generally are not curative, and the intent of treatment is to control the disease for as long as possible, to control symptoms and to extend a person's life. So how do we treat metastatic breast cancer generally? Usually we focus on starting with a particular treatment for a person specific to their breast cancer, and then at some time when that treatment is no longer effective because of typically resistance that develops in the cancer, we switch to another treatment and so on over time. Breast cancer is divided into 3 major subtypes, and there are other ways to break this down, but generally speaking, we have the most common kind of breast cancer, which is ER-positive disease, and then HER2-positive disease and triple-negative breast cancer represent a smaller portion of these. In the metastatic breast cancer setting, these proportions are a little bit different, with triple-negative breast cancer representing a little bit more breast cancer than in early stage disease, HER2-positive a little bit less, and ER-positive is somewhere around the same, about 2/3 of metastatic breast cancer. So what about HER2-positive disease? It's important to first think about what does HER2 mean? HER2 is a cell surface signaling protein on cells in general. And this is a cartoon picture of that, but I think it's a helpful way to think about what is HER2. And this is, if we think of this as sort of the edge of the cell, if we're looking at a cross section of that cell, there's the HER2 protein has both an extracellular out of the cell domain or area, and then also an intracellular or inside the cell space, and that those two work together to communicate from outside the cell to inside the cell and to then promote growth and other signals. And when the HER2 protein gets together with a partner or dimerizes, it then sort of turns on, if you will, and can do that growth promotion signaling. In a normal breast cell, there are fewer than 10,000 copies of the HER2 protein across the cell surface. And so this is, again, a cartoon, but gives you an idea of what that might look like if we were to zoom in on a specific breast cell that is not a cancer cell. But in the setting of HER2 positive breast cancer, we have HER2 gene amplification, which means that there are many, many more copies or a dramatic overexpression of the HER2 proteins. And there's another version of what that might look like, where we see more than 2 million copies of HER2 proteins on a single cancer cell. And as you can imagine, that can cause an dramatic increase in the ability of the cell to signal to grow and divide, and therefore promote breast cancer. The way that anti-HER2 therapies work, and trastuzumab being the first anti-HER2 therapy that was developed, but this is common to other anti-HER2 therapies as well, is that it can bind to the HER2 protein and then block the HER2 function downstream from that HER2 protein. And additionally, it can also bring the immune system, we believe, to that cancer cell and to promote immune attack of the cancer as well. So how do we treat metastatic HER2 positive breast cancer specifically? We think similarly to how we think about metastatic breast cancer generally, is that we start with an anti-HER2 treatment, and typically we would continue to use anti-HER2 treatments across the cancer journey. HER2 positive breast cancer has been what we think of as, some people would call, a precision medicine success story. And that is because of the combination of our understanding of HER2 positive breast cancer and the development of medications to specifically address the HER2-ness of the breast cancer. Most patients now who have stage 1 through 3 or early stage HER2 positive breast cancer are cured of the disease, not all, but most. And therefore, we also have about half of HER2 positive metastatic breast cancer that is actually diagnosed when it's already stage 4. So the proportions here are different than in overall breast cancer. But the treatment intention for HER2 positive metastatic breast cancer has still focused on symptom control and longer life, but not on curative intent treatment. And we start to wonder about this when we think about the fact that we have multiple available, highly effective, non-cross-resistant HER2-directed therapies that are used right now in sequence. And when we start to think about how these medicines have worked, and we look at what this is, you may be familiar with, or maybe not, but I'll explain a little bit. This is a Kaplan-Meier curve, which is a way that we evaluate how well a drug is working in a clinical trial by looking at two groups of patients who are receiving usually two different kinds of treatments, and to measure both how long somebody is able to stay on the therapy. So here on the y-axis is what we call progression-free survival, but meaning how long someone could stay on the treatment without, or how many patients could stay on the treatment without needing to change to a new one. And this is time across months. And this is at the time, this is a really important clinical trial called Cleopatra, where we had follow-up all the way at 8 years. This is quite a long time on a clinical trial. And we're able to see that at 8 years in the group who received the new treatment, which was pertuzumab, 16% of patients had not had to change their treatment because their cancer was still really well controlled by this approach. So this led us to wonder whether there was something else going on here and whether we should start to be thinking about HER2 positive breast cancer in a different way. And we wonder, and we don't know this, but are we curing HER2 positive metastatic breast cancer? Is this a signal that's telling us that that's what's going on here? But we don't know. How would we know if we're doing this? Right now, the standard is still to keep patients on these anti-HER2 medicines indefinitely, because we don't have another way to identify which patients might not have cancer in their body any longer, or if there are patients who don't have breast cancer in their body any longer. We wonder about this, and some patients may stop treatments either because of toxicity or after a discussion with their provider. But right now, there's no guidance on how to do this or when to do this for patients. So I wonder, because of the research that I do, how could liquid biopsy help? So when we think about liquid biopsy, it's important to think first, just what is a biopsy? A cancer biopsy is a sampling of a cancer, which can be either from tissue or blood or even other bodily fluids, that's done to assess how a cancer appears under the microscope, what it looks like, which proteins might be expressed by a cancer, what gene expression levels are in a cancer, which is usually we see by the RNA, and then what gene changes we might see in the cancer through the DNA. And we can get all of these to some degree from a tissue biopsy. But when we think about liquid biopsy historically, we've really only been able to look at the DNA changes, though this is changing somewhat now. But this is really important to think about how we can use a blood biopsy. And tissue biopsies are very important because we can only see some of these changes in the blood, but it's also important to remember that they can be very challenging to perform. They can be uncomfortable. They might not be safe for a particular patient. And they also might not give us all the information that we want and that we need. So we have been searching for cancer in the blood for a long time, although it's very recently become much more of interest. But this isn't new. You may all be familiar with things like tumor markers such as CA2729 or 15-3 or even CEA, circulating tumor cells, which are actually approved in metastatic breast cancer for prognosis. But we also have a word of caution from the CTC setting. This is a figure from an important study that was done some years ago now that looked at whether you could use CTCs and the lack of change in CTCs to guide whether somebody needed to change their therapy. And so unfortunately, though this was a really important clinical trial, the investigators did not see any change in either progression-free or overall survival for patients who were on the study, which is a disappointment. So what's different now, and why should we refocus on the blood-based biomarkers or blood cancer or cancer in the blood? Well, now our current technologies are many orders of magnitude more sensitive than even CTCs. Our current therapies, this is really important, are much more effective. And this is particularly when we think about HER2-positive breast cancer. And when we pair these highly accurate diagnostics or tests with highly effective therapy, we may be really able to make a difference here, though we need to test that that's true. So what is cell-free DNA and where does it come from? Cell-free DNA or cfDNA is DNA pieces that are in double-stranded DNA pieces that are released by cells and can be found in the blood. Circulating tumor DNA or ctDNA is a cfDNA that comes specifically from the cancer cells, and they're characterized by cancer-specific changes. Most of the cfDNA is actually released by normal white blood cells, which makes the technologies that we use and the sensitivities of those technologies to detect ctDNA very important. We see higher ctDNA levels with more cancer in the body, with liver metastases, for example, and then in certain cancer subtypes, specifically triple-negative breast cancer. ctDNA can be a rich source of cancer-specific information. We can look at mutations. We can look at copy number changes, the number of gene copies, for example, HER2-positive disease. We can look at gene fusions and then even things like DNA methylation, which are changes thought of as or known as epigenetic changes. But when we do these tests, we trade sensitivity of the test for the coverage of more genes and vice versa. So we don't want to use the same test to ask whether somebody has a particular mutation, for example, as the test we might want to use to ask, is there any cancer remaining in the body, for example. We can use ctDNA across the disease spectrum. There's a lot of efforts right now looking at screening and diagnosis through blood-based tests. We can think about treatment monitoring, MRD detection or minimal residual disease detection and molecular genotyping, and then also detecting resistance. And all of these may require different approaches, different tests, and different features of those test results. And it really all comes down, and when we think about which test to use, is what do you want to know? What do you want this test to do for you? And it's important to think about that before a provider orders a particular test for a particular patient. So the questions for ctDNA that we can ask of ctDNA in HER2-positive metastatic breast cancer can include things like, can we predict a cancer's response to treatment? Can we monitor a cancer's response to therapy? Could we use ctDNA to understand how a patient is likely to do? Can we discover alterations of resistance in a cancer to guide therapy now or to guide research to develop new treatments? And then can we use ctDNA to understand whether a cancer is gone? So before we could do any of this, we needed first to understand whether ctDNA that we saw in the blood or ctDNA was the same and had the same kinds of alterations as the cancer that we found in the tissue. And this is a figure from a paper that we published now a number of years ago looking at that question. And we saw indeed that when you looked at the cfDNA or and to look for the mutations in the ctDNA, that they were basically the same, 88% of them were the same as what we saw in the tumor mutation. So this is very encouraging, and this and other studies led us to think that this was okay to use the ctDNA to understand what was going on in the tumor. And so from that work, we wanted to understand, could we really know or understand resistant HER2-positive metastatic breast cancer? And we worked in a sort of the same setting, but with a sort of a slightly different approach to ask whether epigenomic profiling of HER2-positive metastatic breast cancer could tell us something about the HER2 positive disease. Right now, when we think about HER2-positive testing from tissue, it really relies on a very complex set of tissue-based tests that we do, and we need a fairly substantial amount of biopsy material from the tumor that's taken. And then it really tells us only, is it HER2 positive, yes or no. It doesn't tell us much about what changes may have happened over time and how much HER2 expression there is, or other things that could be signals of resistance. Cancer epigenetics, these are the kind of gene behaviors that are not related to the gene sequence, can reflect the current cancer status. And so we can actually take a blood sample to do epigenomic profiling from the blood to capture the current cancer behavior. And we've done this with our colleagues who are in Matt Friedman's lab here at Dana-Farber and with Sylvan Baca, another one of our colleagues. And we've asked whether we could look at pieces of protein that are pulled down from epigenomic tests as well as methylation. And we were able to apply this new assay that took just a milliliter of blood from 130 patients with metastatic breast cancer, a mix of HER2 positive and HER2 negative breast cancer, and to ask whether we could see the HER2 status in these patients' cancers. And this is a somewhat confusing figure, but what I wanted to focus on is just that when we did do this test, we could see that first, it could separate HER2 negative breast cancer from HER2 positive breast cancer, and that this really captured a lot of different features across the whole cancer genome. So they could capture areas that were across the entire genome, areas that were within the specific HER2 gene, and then again, the HER2 entire genome, and they were different from one to another. And when we applied that classifier to ask whether it was HER2 positive or negative from the blood, so this is from the tissue first, and then looking just in the blood from a milliliter of sample, we could see that in 88% of cases here, that's not exactly right, but there was that it was a very good test when we looked at all of the samples to separate HER2 positive from HER2 negative. And when we looked at the samples where they had a high level of ctDNA, which we measured by another method, we saw that it was even better with an AUC of 0.97, which when you think of, you want it to be as close to 1 as possible. So this is pretty good. So we were really excited about this approach to try to understand HER2 positive disease and be able to identify it from the blood. And we actually then looked across HER2 negative breast cancers all the way, and sometimes there are these grayer areas, HER2 low, you may have heard about, but looking across the spectrum, and saw that the test results correlated with HER2 status. We were very excited about this because there's more interest in understanding patients who might have HER2 low breast cancer, but also because we really want to understand over time how HER2 positive disease is behaving and whether it might be changing with time and becoming potentially more HER2 resistant, or even taking this approach and using it to apply to different parts of the cancer to better understand why does a cancer become resistant or whether a cancer is becoming resistant And we hope that in the future, we're able to use this kind of a test in real time to help patients with HER2 positive metastatic breast cancer better understand the cancer and then to give better treatments as a result. So I wanted to stop there and change gears a little bit to thinking about what we call minimal residual disease, or when we think about very, very low levels of cancer in the blood, and how this might be important in HER2 positive metastatic breast cancer. So when we step way back, we think, we know that breast cancer is really common. Unfortunately, it affects about 270,000 patients a year, and that there are many millions of women who are living as breast cancer survivors. But many of these women, who are mostly women, patients living with breast cancer, their breast cancer is gone, but some of them have what is left as minimal residual disease. And this has mostly been thought of in the earlier stage setting, but we wanted to bring this into the metastatic setting to understand really more in the number 3 and 4 here, whether we can cure patients who have metastatic minimal residual disease, or number 4, consider stopping treatment in patients with metastatic disease and a durable or long-term or exceptional response to treatment. So the reason why this is a little bit harder than working in the setting of more extensive metastatic disease is that there are so much lower levels of ctDNA, or tumor fraction is much, much lower in this setting than in more advanced disease. And so each tube of blood contains just a limited amount of ctDNA. And therefore, the approaches that we use need to be really sensitive. And the most sensitive tests right now require tumor sequencing and then the development of a personalized test to be able to gather every single molecule that you can to understand whether there's cancer there or not. The way that we do this is we take a piece of the cancer when it's been removed via biopsy or surgery, and we can actually take it when it's even if it's been removed many years before, and do sequencing on that initial piece of cancer and understand what the specific cancer-related changes are in the cancer. And then we develop a test that's made by a patient-specific tumor fingerprint panel from either whole exome or whole genome sequencing, and then use that specific test to apply back to blood that's been drawn from a patient, and then can ask whether that we can see cancer in the blood or not. And then what we did originally is just to correlate whether we saw that in patients who had developed metastatic disease or not. And our group and many others have shown that in these small retrospective studies, that a positive ctDNA test was strongly associated with later metastatic recurrence. Unfortunately, a negative test in the earlier versions of these tests was not as helpful because it didn't pick up every single molecule, and the tumor-informed testing was most sensitive. We also saw that the technology was rapidly developing, and we're encouraged that these tests are getting more and more sensitive almost every day, but certainly by the year. But these studies didn't tell us how many patients with lower risk breast cancer had ctDNA. We didn't know whether most patients with ctDNA in the blood had scans that would show metastases if we looked. And we didn't know from these these tests looking back at patients who had historically had breast cancer, whether we could improve outcomes for patients with ctDNA in the blood by either preventing metastatic disease, improving quality of life, or lengthening lives. And we don't know either whether ctDNA would go away when we treat it, and is that a marker that we could use in studies? So it brings us back to HER2 positive metastatic breast cancer and some of the clinical trials that we're doing right now. We have developed a study called the Stop HER2 study that goes back to that question of whether patients who have been on their anti-HER2 therapy for a very long time actually might not need to continue on the therapy because either the cancer is gone or the cancer has been so well controlled that perhaps the treatment is no longer needed. And so what we are doing is and this study is supported by Komen. We're very thankful for that support. But patients who have HER2 positive metastatic breast cancer and have been on their treatment, their first line treatment, for at least 3 years from the time of diagnosis. And patients are asked, this is not randomized, whether they want to stop their anti-HER2 therapy. If they say no, but they'd like to participate in the study, they enter cohort 1, which is an observational cohort. Patients continue their anti-HER2 therapy, and they're followed every 12 weeks with restaging scans, a provider visit, and then are followed for 10 years or until they experience disease progression. We do MRD analysis, which is using one of those ctDNA guided tests, but those tests are being done retrospectively. So we're not doing them to guide therapy here because we weren't sure exactly what the test results would mean in this setting. And so we're going back and analyzing those results afterward, but we're very much looking forward to what those tell us and whether they can predict who could safely stop or who might need to continue. The more sort of the interventional part of the study is group 2 or cohort 2. So if patients want to enter the study and stop treatment, they enter the cohort 2, which is that they stop their anti-HER2 therapy. There are 52 patients in this group, and they're followed in the same fashion for every 12 weeks with restaging scans, a provider visit, and then again, the blood testing for MRD analysis that's being done after the fact. If patients have ongoing response, they can continue off therapy indefinitely with the discussion with their treatment team. If they have progression of disease, they're recommended to restart their original therapy, and all patients are being followed for up to 10 years or until progression. The primary endpoint for the study is 1 year progression-free survival off therapy, and we've been really encouraged to see how enthusiastic patients have been for the study. We're also, after being just open for just about less than a year, we had already accrued 27 out of 30 for patients in cohort 1 and 26 out of 52 in cohort 2. We're right now paused in the study because we have to do an interim analysis to make sure it's safe before we open again in hopefully later this summer. The other question we wanted to ask, also related to HER2 positive breast cancer and specifically to in this sort of questions about circulating tumor DNA, is whether we could increase this number of patients who might have exceptional responses to the anti-HER2 therapy and sort of move these curves up so that more patients are having exceptional response than they were in the Cleopatra study shown here. And so we have designed the SAPPHO study, which is a single-arm phase 2 study of curative intent treatment of de novo HER2 positive metastatic breast cancer. And this is about to open. It's IRB approved and is hopefully will be open before July 1st. This is enrolling patients with stage 4 HER2 positive disease at diagnosis and who have not had prior treatment for their breast cancer. If they want to enroll, they have a biopsy at baseline, and they start on what is the standard treatment right now for breast cancer that's HER2 positive metastatic. For 12 weeks, they receive a combination of trastuzumab, pertuzumab, and a taxane. After that, they have restaging scans. They transition to trastuzumab deruxtecan or Enhertu for 18 weeks. They have repeat scans and then transition to Kadcyla or TDM1 in combination with tucatinib, and then transition to, for 12 weeks, have the same repeat scans, and then transition to the combination of trastuzumab and pertuzumab plus tucatinib for 1 year, and that's the maintenance regimen. After they get to the end of their maintenance regimen, if they still remain progression-free, they will stop their treatment unless they have HER2 ER positive breast cancer that's also HER2 positive, and those patients would continue on their anti-hormone therapy. And we're asking at 4 years, how many patients remain off their systemic therapy and without progression of disease. And so we are really excited to see this study get going. We've had a lot of input from our patient advocates in the TBCRC, and we're really hoping that it is as successful as we hope it will be. So future directions, I think this is, hopefully we've shared a lot today, but I am optimistic about the state of liquid biopsy in breast cancer generally and on HER2 positive breast cancer specifically, that the future directions include just knowing that these technologies are varied and that they're very rapidly developing and evolving. The clinical trials are right now in planning and underway to test whether these tests can really make a difference in how well and how long patients live. We are not there yet, but I'm again hopeful and optimistic that we will get there soon. I wanted to thank our mostly the patients and their supports, as the research that we do is often involves patients donating their biospecimens, their blood and their tissue. And we're very thankful to them for this. We could not do it without them. And thankful to our research team. We do a lot of very collaborative work, and they're just some of the people who participate in that here. And then finally, thank you to our funders. Susan G. Komen has played a really important part in my research, as well as these other funders listed here. So I will stop there, and looking forward to questions from all of you.
Thank you so much, Dr. Heather Parsons. I myself am highly impressed with all that data, and I look forward to reviewing. I took notes, but it was, lots of wonderful information. So we do have some questions that came in. First question submitted says, I was diagnosed a stage 1 triple positive breast cancer patient in 2019. HER2 positive, but no lymph node involvement breast cancer. In 2019, 2020, I went through a surgery, chemo treatments for 3 months, radiation for 1 month, and target medicine for 1 year. I'm taking letrozole 2.5. I have been taking letrozole since November 2019. It's going to be 5 years after I started to take letrozole. Can I stop taking letrozole when I take it for a full 5 years? The first part of the question.
I would defer to the patient and her provider talking about that. I think I don't want to give medical advice without knowing the full context, but I think it's certainly worth a discussion with her provider, with their provider.
Right, okay, thank you. And then it said, should I continue to take it for another 5 years? And regarding to follow-up, do I need to do an MRI every year besides a mammogram or ultrasound? I just did a cancer genetic testing last month, and it turned out that I didn't have any inherited cancer from my family. What advice do you have for me, and what do I need to do to continue to watch myself for preventive purposes?
So I think all those questions, just to keep it a little bit more generalized to everyone, is that when we think about I'm glad to hear that patient is doing so well. I think when we think about imaging that we should do when someone has early breast cancer, is we want to do imaging of the breasts usually annually for most patients with mammogram. If there's another reason to do MRI or other imaging, usually MRI, that's usually because of either a strong family history or other known genomic risk, or like a BRCA1 or 2 mutation, for example. And it's worth a discussion with your provider about what kind and how often the imaging should be done, because there are risks of doing too much imaging and also of doing too little. So that's a
Parsons.
Sure.
Next question. Is there research or studies that show a combination of both trastuzumab and pertuzumab, Herceptin and Perjeta, is more effective for progression-free life longer than one alone?
Yes, so that is actually really important. The study that I showed a few times, that Cleopatra study with the 8-year survival report, and the long sort of what we call tail on the curve, meaning lots of people doing well for a long time. It showed that the combination of Perjeta or pertuzumab and trastuzumab or Herceptin patients did much better than if they just took Herceptin alone. So it is better, and Perjeta can add some toxicity. Usually it happens to be diarrhea is the most common thing. There can be some other things, but often we're able to get that under control for patients, and we generally recommend that should be the treatment that somebody takes for metastatic HER2 positive breast cancer.
Wonderful. Is blood biopsy to answer the question of how much minimal resistant disease remains effective if patient currently shows no evidence of disease post-treatment?
So it's a great question. We're trying to understand that in the Stop HER2 study and in the SAPPHO study, and we have some other sort of ways to think about understanding that. Right now, we don't know whether a the presence of the ctDNA, or minimal residual disease, or MRD. Those are all the kind of the different names for the same thing. Whether we know that if we find it in somebody, that is usually a sign in early stage disease that means that there is a more likely a risk of cancer coming back. And somebody who has already, we know that they have metastatic breast cancer. We don't know if finding that means anything specifically about the cancer, if the levels are steady. We're trying to understand whether if it goes away totally, if that means that somebody could safely potentially stop their treatment. We don't know that yet, so I'm not advocating for anybody to do that. We are hopeful that might be a tool we could use to better understand that, but we don't know that yet. And it very much depends too on the kind of the test that we use, because the tests are all very different in how well they can detect the levels of ctDNA.
And are blood biopsies often done regularly or just at the start of treatment when they're first diagnosed?
Yeah, so I think it's often in metastatic breast cancer, we encourage, especially for people with hormone receptor positive breast cancer, but HER2 positive breast cancer too, is to have a blood biopsy at the beginning. And those blood biopsies are usually looking at whether we can detect alterations or sometimes mutations in the cancer that could help us guide treatment, either to say, this cancer is likely to develop resistance, and so maybe we should give some additional treatments. There's work to do that in patients with PIK3CA mutations, for example, or to have just a starting point, because we know cancers can evolve and change over time. And so later, if we have a baseline test, we might be able to say, this cancer developed this resistance change, and so therefore we might want to treat it in a different way. But so I guess the answer would be, I would check at the start, and then typically if I'm going to change treatment again, I might, because the cancer seems like it's other signs show that it's growing or changing, then I would recommend another test at that time to check whether the cancer has developed any other changes in the ctDNA that might make us want to change the treatment a little bit differently. It's not quite as well used in HER2 positive breast cancer for that reason, because all of our treatments typically involve anti-HER2 therapies, not just, and so we don't usually let go of those. We don't give up on those, even if we see something different in the cancer.
Wonderful. So that leads us to the next question. What's the difference between HER2 positive and HER2 negative?
Yeah, that's an important question. And it is, so HER2 positive breast cancer is, and I showed this sort of at the beginning, I think the cartoon is helpful, but HER2 positive breast cancer is a breast cancer cell where it has developed many, many copies of the HER2 gene and the HER2 protein. And so it can grow based on the having that HER2 protein, lots of them. ER positive, or estrogen receptor positive, is sort of a similar thing, but with a different gene, estrogen receptor. And so HER2 negative breast cancer doesn't have that overexpression of those many, many copies of HER2 that the HER2 positive kind of breast cancer does. Similarly with ER positive breast cancer has many more copies or more expression of the estrogen receptor, whereas ER negative disease does not. Does that make sense?
It makes sense to me. I hope.
Okay, good. I hope it makes. Well, that was clear.
To our question and a questionnaire question person. I hope. Well, we'll see if there's a follow-up question to that. So we have another one. Have you found any differences between ductal, lobular, and inflammatory cancers in response, or MRD?
So right now, we don't have, there's not very clear data on that yet. It's a very important question. The inflammatory breast cancer, we're actually doing a study with Dr. Philippa Lintz, who's our inflammatory breast cancer primary investigator at Dana-Farber. She's leading a study looking at whether we can, the sort of features of ctDNA or circulating tumor DNA in IBC. And we are looking forward to understanding better the ductal versus lobular, but we don't yet have data on those. important though.
So many great questions.
Yeah.
And let's see. Next question. I have metastatic HR positive, have had this shot so far, and Verzenio as well as 3 radiation for T12 bone was involved. I was diagnosed with breast cancer in 2009, first time, and now this year. Originally had 7 weeks of radiation, only with lumpectomy. Now have had mastectomy and all my lymph nodes removed. I'm so overwhelmed. Going forward, what more can I do?
So I'm sorry, that is a tough,
Sorry.
it's
Yeah.
such a tough diagnosis. And I think one of the things that's so hard is that the treatment for breast cancer is so complicated, and there are so many different, can be so many different teams involved and different parts of it. And it's important to have clear explanations, and some patients don't always, unfortunately, don't get that. But I think asking lots of questions and keeping in touch with your provider, and if you don't feel like you're getting the answers that you need, to ask more questions. And organizations like Komen can also provide some educational materials too that I think can help people feel reassured by, in addition to the conversations with their team.
And looking at webinars like this and seeking additional information, not just going to the Dr. Google, but
Yes.
seeing doctors present
Yeah.
information that is accurate, I think
Yeah.
is such a blessing. I love this opportunity to be able to see you face to face and hear your responses to these very critical questions, that pertain so deeply to our lives. It's so essential. So we do have another question.
For us too.
If thank you. If one received TCHP resources linked oh, no, I jumped. If one received TCHP pre-op and Katsula post-op for stage 2B with partial response, what else would be available when the triple positive becomes metastatic?
So there are lots of treatments available when disease becomes metastatic. There is because the treatments have been thankfully so effective for metastatic HER2 positive breast cancer, and now we have many of them, not just Herceptin, but a number of other treatments, that there are pretty specific treatments that we recommend in a specific order. So trastuzumab, pertuzumab, and taxane are typically the first treatment that people would get if the breast cancer becomes metastatic. But if that's not effective, there are many other approaches.
Another question, it says, this research is very interesting. Thank you for sharing. I would agree with that.
Thank you.
For those of us with daughters, nieces, etc., could this research also be used as a predictor for genetic markers on top of the currently tested genetic markers, i.e., will it help predicate if they are at a higher or lower risk based on patient HER2 positive levels, high or low?
That was a great question too. So currently, if somebody has a strong family history or a parent with a history of breast cancer at a young age, or they have a parent with a history of or grandparent typically, or sibling with breast cancer and a known genetic change, that means that they're at increased risk. So people usually think of BRCA1 and 2, but there are others that also can be associated. CHEK2, PALB2, there's a list of those. That's a really important part of testing, in all patients with metastatic breast cancer specifically should have genetic testing done, because there are changes that we would make to their treatment, not just for their family's health, but also for theirs. But to the question about ctDNA and how it might help, there's a lot of really exciting work going on right now in screening for all sorts of different kinds of cancers, including breast cancer, using a blood test. So a test that looks at ctDNA in people who don't have known cancer. And there's a center at Dana-Farber. There are other centers around the country who have them as well, to help understand these tests and also to develop better tests. Right now, they're not yet. I would say I don't recommend people getting them, but but they are available and they are rapidly changing. So I hope that someday soon that patients who have, or family members of patients who have a strong history may be able to potentially have that kind of a test that would help them understand whether they're developing cancer in its very early stages or at risk of developing very early cancer, so that they could have treatment before it's more advanced.
Thank you.
Mm-hmm.
My next question is, if I am having PET CT scans every 4 to 6 months, is a mammogram necessary?
So I would assume that person is talking about already having metastatic cancer. I don't know, but that we don't typically, if it's not the case, it's not recommended to do PET scans or other, whole body scans to look for breast cancer if it's stage 1 through 3 and has already been treated and has not come back. But in stage 4 breast cancer, so metastatic breast cancer, we do imaging like PET CT or CT scans to look for if the cancer is still controlled or is growing or spreading. We don't recommend mammograms for patients because the point of a mammogram is really to screen for an early breast cancer, and if it has already spread, that test is not a helpful test. The more important helpful test is the body scan to be able to understand what's going on with the cancer right now.
Exactly. We have a patient that is asking, I know that this is about metastatic, but I'm HER2 positive. Nodes negative tumor, 2 millimeter, stage 1A microinvasion. They do not seem to know what to do with me due to the microinvasion. Is it enough to treat? I would like more input. My insurance denied clinical trial, so my question is, how do I get Herceptin that I feel I need? I had a lumpectomy and will have radiation. How do I stop HER2 replication if no med?
So that's to bring it like sort of generally to speak to everybody. I think there's pre-cancer and there's stage 0 and there's stage 1 cancer, and there's microinvasion is sort of somewhere in between. For stage 0 cancer, also known as DCIS, we know that Herceptin, even if it's HER2 positive, it actually doesn't help anybody do better. So we recommend against it for that kind of cancer. In the microinvasive setting, it's not very clear that it's helpful, and it's always a discussion of the tumor board. It's always a lot of hand-wringing about whether that is going to be a part of the treatment that could be helpful. But if the treatment team is not recommending that, I would just talk with the treatment team about that. But it is a controversial area, and it's not. The good news is that somebody with microinvasive disease is very, very likely to do very, very well and not to hear from that breast cancer again.
Wonderful. I have a question here. Is the liquid biopsy similar to the Signatera test?
Yeah, so the Signatera test is an example of a liquid biopsy test. And it's an example of a test that's what I refer to as tumor informed. So meaning that they do the sequencing of the cancer when it's the tumor tissue, and also actually do the sequencing of your regular sort of what we call germline DNA, and then develop a personalized test for a person, and then apply that to the plasma, to the ctDNA. Those tests are not yet proven to be helpful for patients, either in sort of changing how patients will do from any real perspective. We're really hopeful that they will, and that's sort of when I talked about the Stop HER2 study, the SAPPHO study, also a number of other studies in early stage breast cancer. There's a lot of work to try to understand whether they're helpful or not, but we don't know that yet. And I don't recommend them for my patients right now outside of clinical trials because of that, the lack of knowledge about what their impact could be.
Wonderful. We have one last question. We're running out of time. So the last question will be, for the Stop HER2 trial, if scans are clear, but the blood test shows something, will they be told?
That's a great question. So that's why I emphasized, and I hope it came through, that the tests are actually being done not in real time. So we are not we're not doing these tests as part of the trial to guide the therapy. So we are doing them after the fact later. And we are, because of that, and because they won't be done in a, what we call a CLIA setting, or a setting where there's been the whole sort of control of the samples all the way through, like a clinical test usually would be, we don't return those results to patients, but they will not have been done as part of the trial, except for later. The goal of this is that those tests, if it works, if we show that it does identify patients who should or should not stop, then we would be able to use those tests in patients in real time to be able to give that result. But because we didn't know starting the trial whether that was going to be, whether it would be important and helpful and how it would work, we didn't feel like it was appropriate to include as a biomarker for the study. If patients are having a test like Signatera outside of the trial, we are collecting that information to include so that we understand, if patients had a Signatera test and they got the results, we want to know that for the study, but we're not doing that prospectively.
Wow.
That's important
I love
question.
all this information. This is so fantastic.
These are great questions.
I appreciate you, Dr. Heather Parsons, for coming on here today. And thank you for sharing your vast knowledge with us. I know as a patient, I really appreciate your time and your slides. Lovely.
Thanks so much, Julia.
With
I
that,
really appreciate it.
Thank you. I get to pass you back over to Gina.
Yes, and my apologies. I have a very hungry kitty who is trying to infiltrate the webinar, so I apologize. This happens all the time. I wish I could say it didn't, but it does. But anyway, we were so excited that you all could join us today for this important event. We want to express our sincere gratitude and thanks to Dr. Heather Parsons and Julia Hughes for being with us here today. Also, I want to thank you all for these incredible questions you submitted. There were so many, and they were all so good and so relevant, and just questions that needed to be asked. However, we did not get a chance to get to all of them. So what we will do after the event, I will download all of the questions we did not get to. I will email them to Dr. Parsons. We will coordinate responses, and we will be able to send that out to everyone who registered for today's event. So do not fret. We will get to your questions. I just apologize. There were so many, we just couldn't get to all of them. Today's session was recorded and will be posted on our landing page very soon, so you can rewatch at any point or view any of our previous sessions that you may have missed. However, we do hope you will help us spread the word about this important content and all of these great virtual events that we do host monthly with your friends, family, and your healthcare professionals. Providers should be a part of the conversation as well. I dropped the link to the survey that we have for the Impact series in the chat. Actually, I think I dropped the wrong link. Hang on one second. I did, in fact, drop the wrong link. This is what happens when you try to do too many things at once. Here, let me get that link to survey. All right, my apologies for that. I do, however, want to give one final shout out to our presenting sponsors for today's event. We want to acknowledge all of them and their generous support, because without them, we would not be able to host these events. Thank you to our premier sponsors, GE Healthcare, AstraZeneca, Merck, and Gilead, and our signature sponsors, Walgreens and Daiichi Sankyo. All right, this series is made possible because of their generosity. Again, please fill out that evaluation. We absolutely value your feedback. We use those evaluations for topics for future events, so make sure you share that with us. Give us some ideas. We definitely want to meet the needs that you have and answer all of your questions. So finally, the next event in the MBC Impact series will be in July, and it will be focused on Metastatic Breast Cancer 101, Ask Me Anything. It will feature Komen's expert metastatic breast cancer patient navigator and hopefully a metastatic patient. So it'll just be sort of a AMA, Ask Me Anything. So bring your questions and we can hopefully get those answers. We look forward to having you log in and join the conversation. Thank you again for joining us today, and thanks to all who made this event possible. Stay safe and stay connected. Have a good day.